Good afternoon. It's afternoon in Istanbul. So hello to all. In this presentation, I would like to review the results of studies made with statins on bone formation. So I will give an update and including also our studies. So statins are valuable drugs. They have various benefits like reduction of atherosclerotic cardiovascular events, LDL-C levels, all-cause mortality. And they additionally have anti-inflammatory and antioxidant effects. In addition to their benefits, there are some risks. And what are they? These are myopathy, and increased risk of NEW-ONSET type 2 diabetes mellitus and hemorrhagic stroke. And liver injury is very rarely clinically relevant. And they are indicated in primary and secondary prevention of atherosclerotic cardiovascular diseases. And there has been raised so much scrutiny on this subject, using them in primary and secondary prevention. But according to the guidelines and according to the recent panel, the overall risk-benefit ratio is on behalf of the benefits, and benefits outweigh the risks of these adverse effects. And the effects of statins on bones are not yet evaluated in these panels or guidelines. So I would like to discuss whether the effects of statins on bones can add an advantage, a benefit, especially to the elderly when used due to comorbidities. And the first report on bone formation came from Mandi et al. It was 1999 and it was published in Science. And they used calvaria in organ culture and treated the calvaria with statins. They used 4 types of statins: lovastatin, fluvastatin, simvastatin, and mevastatin. And they were able to show that statins induce bone formation, which is comparable to positive controls like fibroblast growth factor and bone morphogenic protein. And on this slide, you see the effects of simvastatin following exposure for 4 and 7 days. And the concentration is 1 millimole. As compared to the control, the effect on bone formation was more prominent on the 7th day. And also, you see on the right, the effect of simvastatin on MG63 osteoblasts, and not BMP4, but BMP2 expression was increased following the exposure, and this was dose dependent. So we see here from this first study that statins effects on bones are both time and dose dependent. And the same study has an in vivo part. And in this in vivo part, you see here on the left, the control group versus simvastatin at 5 and 10 milligram per kilogram day, and also the positive controls. And effect of simvastatin on bone formation after local subcutaneous injection over the murine calvaria for 5 days. And the evaluation was performed on the 21st day. And on the right, you also see them in a graph. As shown, simvastatin has, again, dose-dependent effect on bone formation, which is comparable to fibroblast growth factor and bone morphogenic protein, which can also be seen plotted on this graph versus the control and FGF. As you see here, there is a dose-dependent effect, the highest at this 10 milligram kilogram per day. And another important study is from Mehta et al. And this study was able to show that statins induce osteoblast differentiation indices. So at the concentration stated in the slide, simvastatin increased mRNA expression for bone morphogenic protein BM2, but not BM4, and vascular endothelial growth factor, as you see in the second graph. And in the third graph, you see type 1 collagen, and additionally, alkaline phosphatase and osteocalcin mRNA levels were also increased. But on the other hand, gene expression for collagenase 1 and 3 were reduced. And this is our study. Our team were screening the effects of various drugs on tendons. So we were measuring the toxicity of the agents, whether they cause tendinopathy or not. So this study investigated the effects of statins both on tendons and also on bones. In the first slide, you see the effects of 3 statins versus control group. In the control group, we observed no calcific deposits, but in the statin groups, we observed these calcific deposits. And these calcific deposits, according to the literature, can be associated with increased expression of bone morphogenic protein, and also the interference of statins with calcium release following interaction with mitochondrial and sarcoplasmic reticulum systems. And in the second part, we investigated the effects of statins on the biomechanical properties of the tibias. And on the left, you see the table showing these, the improvement in these biomechanical properties. And as compared to the control group, the ultimate tensile force, elastic modulus, and the yield force were investigated. And 3 statins again were used as in tendons, and 2 doses were selected. And as you see here, regarding the UTF and the yield force, the parameters were significantly improved as compared to the control group. But for the elastic modulus, simvastatin and rosuvastatin showed these effects, and atorvastatin was not significantly different. And at these doses we used, and at this 3 weeks administration period by gauge we used, bone mineral density did not change significantly. So there are many studies, preclinical studies, which showed and could not show the effects of statins, whether they could prevent osteoporosis or not. For example, there are ovariectomy models which used smaller doses and failed to demonstrate the effects. I will discuss them in the following slides. So I would like to give some examples from the clinical trials, not trials, but clinical data. So these data are usually from the databases of various nations, and this is from Denmark. This is the National Hospital Discharge Register, and a relatively high number of cases and controls were included. And use of statins was associated with a reduced risk of any fracture, as you see, when the odds ratio is adjusted. And statins and non-statins are compared, there is a significant effect. And also in this study, Reinmark and et al. Could show that risk of hip structure decreased with increased accumulated dose of statins, which was true in men and women, and also in subjects younger and older than 65 years of age, which you see in this slide. Only for hip fracture they were able to demonstrate, and this is a 5-year follow-up study. You see here the defined daily doses. Low if DDD is below 100, medium if between 100 and 999, and high if it's over 1000. And they showed that, they found that hip fracture risk decreased as the number of DDDs increased, whereas no clear dose response relationship was evident for fractures at the spine or forearm or for any fracture. This is a Finland study, and this study analyzed the effects of statins following a 5-year exposure. And women between 45 to 75 years of age were included, and these women had no prior hospitalization for fractures. And the low energy hip fracture was analyzed. What is it? It's defined as a discharge diagnosis of hip fracture without any other fracture code or without road traffic accident codes as extrinsic factors. And there were 3 cohorts. And the first is the statin cohort, the second is the hypertension, and the third is the population cohort. So what is specific about these cohorts? In the statin cohort, the women started using statins, and they were adherent to the statins between this 5-year follow-up period. And the hypertension cohort initiated and were adherent to the antihypertensive medicines, and population cohort was randomly selected. And following this 5 years of follow-up, they were able to show that here, as you see, around 30% reduction in the statin cohort as compared to hypertension cohort or population cohort. So a statin versus both cohorts, then they were able to show after analyzing the data from the registry. And this review in 2017 is a systematic review and meta-analysis. And there are 13 studies involved. There are 23 observational and 10 randomized control trials. And the total number of patients is over 300,000. And they show that statins decrease the risk of overall fractures and also hip fractures. And the use of statins was associated with increased bone mineral density for total hip, lumbar spine, and also bone formation markers were increased, and no positive effects on vertebral fractures, upper extremity fractures, BMD at the femoral neck, bone-specific alkaline phosphatase, or others were found. So as a result of this meta-analysis, they concluded that statins are effective in reducing the risk of fracture. And this study from Lin et al., a recent study, they also evaluated the effects of statins versus daily defined doses. And as you see in the table, the higher, the more accumulation of DDDs, the higher prevention can be seen. Lin et al. investigated the new onset osteoporosis for this 13-year follow-up period, and this is again a retrospective study. And new onset osteoporosis risks showed a declining trend. And they were also able to show that statins like simvastatin and atorvastatin, rosuvastatin, the high and moderate potency statins, as indicated here, they showed a significantly lower risk as compared to the low potency. And here is an interesting study, why I included it in this presentation. They investigated, again, a retrospective analysis, the statin users versus statin non-users in chronic obstructive pulmonary disease and also in the control. So because some drugs like corticosteroids used in these patients are associated with osteoporosis, and they checked whether this can be caused by statin use, and they showed that patients with COPD receiving statin therapy has no increased risk of new onset osteoporotic fracture. And here, the revision arthroplasty is evaluated. This is from the databases of two countries, United Kingdom and Danish hip arthroplasty. This is a review from Sorail et al. And this is, again, a very recent review. And as we know, statin therapy seems to promote osteointegration and reduce periprosthetic osteolysis. And according to the UK data link, the statin users were matched to non-statin users. According to the data analyzed, statin prescriptions were associated with a reduced risk of joint arthroplasty due to rheumatoid arthritis, but not to osteoarthritis. And these two databases together, when the statin users were ever users or never users were compared, the risk of lower limb revision arthroplasty was reduced. And this effect was time dependent. And as a result, what can we say? Can we say that statins are potential agents for prevention and treatment of osteoporosis or revision arthroplasty? We can increase the questions. Now, according to the preclinical trials, we know that statins induce bone formation biomarkers, improve biomechanical properties, but these effects seem to be dependent on the potency of the statins used. And this may also, dose dependency and time dependency is evident in these trials. And these may be the reasons why some studies may fail to show the effects. And adherence seems to be also another important factor. Adherence to statins increases the effects of statins on bone formation. So as a result, I can say there are promising results, and but randomized controlled prospective studies will be very valuable to define the effects of statins on bone formation. So thank you for your attention.